Good morning, and welcome to those who are present in the inquiry's hearing room in Edinburgh, and to those who are following proceedings on our YouTube link. Today is the first day of our hearing in relation to the Royal Hospital for Children and Young People in Edinburgh and the Department of Neurosciences. If I can say a few words on housekeeping before we begin today's evidence. We're sitting this week, and we plan to sit next week. That's the week of the 4th of March, and then the week of the 11th of March, although we will not be sitting on the Mondays of these weeks. We have available the week afterwards if we require it. As you will understand, although we have a timetable or as it were, a draft timetable for witnesses, it may be that that requires to be changed or to accommodate the length of time that the evidence takes. Now, as you're aware, the questioning in this inquiry, as is usual in inquiries, will be led by counsel to the inquiry, John McGregor, King's Counsel. That, of course, is subject to the provisions of the inquiry rules, and in particular, Rule 9. Now, I'm aware that there have been some Rule 9 applications lodged with the inquiry. Whether these will be insisted upon, we will see in due course. The plan would be to invite Mr. McGregor to lead his witnesses. At the end of their evidence, the opportunity will be given to legal representatives to consider whether they wish to apply to ask questions of witnesses. And in that event, I would ask you, first of all, to discuss the matter with Mr. McGregor, and if matters can't be resolved, then I will listen to any application that may be made for legal representatives to question witnesses. I issued a procedure direction in relation to closing statements, which I would hope that core participants received on Friday of last week. We may have the occasion to look at that again, but broadly speaking, I will be inviting written submissions, first from counsel to the inquiry and then from legal representatives of core participants, with provision after that for oral submissions on a week in June. Can I just say, as a matter of housekeeping, when it comes to written statements, it's convenient that they be in a Word format, which is easier for the, well, quite frankly, easier for me to deal with. That, I think, is all I have to say in relation to housekeeping, although I've been told to, well, my apologies for that break. The problem related to our ability to live stream on YouTube. If this problem re-emerges, what I'm proposing to do is we continue recording, and with transmission being available, I suppose the expression is catch up. Well, shall we invite Mr. Henderson to rejoin us? I'm sorry about that, Mr. Henderson.
No problem.
Technical difficulties, which I hope will not be repeated. Mr. McGregor.
Thank you. I think, Mr. Henderson, just before the break, we were looking at SHTM 0301, so we're in bundle 1 at page 1119, and we've just been looking at paragraph 7.13 in relation to table A1, and I think you just were about to go on and explain what your understanding of what table A1 was for you as an estates officer.
Yes, it's the table we would refer to when we were looking at what should the air change rates be in this room. For example, if we were refurbishing a ward or refurbishing an area, we would look at that to see what the air change rate should be for that area.
If we could look on to page 1159, please, and to paragraphs 8.64 and 8.65. I won't read these out, but these paragraphs that you're familiar with in relation to a validation report.
Yes.
Now, the inquiry is considered before the concepts of commissioning and validation, but can you just explain what was your understanding of what a validation report was?
A validation report is basically a report that concludes that the entire system, from air intake to air extract, and the environment that system is serving, is suitable and sufficient, and will basically meet its needs and fit for purpose.
So you'd get a short report effectively saying that the system's only is going to be fit for purpose and only require routine maintenance.
Yeah, yes.
Now, if you were engaging on a project for NHS Lothian, would that be a report that is produced by the contractor, or would you get an independent individual in to complete the validation report?
If it's okay, can I refer to my experience in this kind of situation? As a maintenance manager, it would tend to be systems that were already installed, so we would be getting the annual verification done by an independent contractor, and that would come to me or one of my colleagues as a report. It wouldn't always be in the format that and I think we'll go into this probably in the format that we're going to discuss today, but it would give you the information required to conclude that the system still met its needs and it was fit for purpose. Okay. With ongoing maintenance.
So in terms of ongoing maintenance, every year the authorising engineer comes in and gives you some form of report. What about if you're dealing with a new build facility or a refurbishment?
Again, it would, for me, that for this instance here, it would depend on the type of procurement method, the contract. This is a building built by and owned effectively by a special purpose vehicle. They carry on at the moment doing the annual verifications for the specialised ventilation systems, and that probably played into my discussions with my IPC colleagues about who should be doing the initial validation. But we concluded eventually and procured an independent authorised engineer to do that for us.
So again, just so I'm understanding a matter of generality, if it's, say, a public-private partnership that a health board's involved in, you wouldn't necessarily see it as your responsibility as an estates officer to get an independent validation report produced? Not
I hadn't come across this situation before, so I'm not saying that, but in a normal one, in a traditionally procured contract, we would go to the independent and get it.
Okay. So if it was a standard design and build contract, you would look to the contractor to provide the validation?
No, we would, the
NHS Lothian would provide that independent validation report on a design and build contract?
Yes, but after the conclusion of the...
So design and build contract, independent validation done by the health board. And I think you were saying really in terms of public-private partnerships, you didn't really have any prior experience before the project and you weren't really sure what should happen.
Yeah.
Thank you. If we could just look on within the guidance to page 1173, please. And this is, I think, the appendix A1 that we've looked at in terms of the guidance. And there's various boxes, starts with general ward. If we could perhaps just zoom in and look, there's perhaps 4 to look at. It begins with ward isolation room. There's ward isolation room, infectious disease ISO room, neutropenic ward, and then critical care areas. Do you see that?
Yes.
And again, I think you've already told us in your evidence that you saw a distinction between critical care areas and requirements for isolation rooms.
Yes.
And are you drawing that from what's stated within this table?
Yes, partly, and partly my knowledge of the clinical activities, but or my kind of partial knowledge of them. But ward isolation room there is an isolation room, and it could be in any ward. It could be a general ward, it could be a critical care ward, neutropenic ward, and then the critical care areas are the areas within critical care as a whole.
So again, just so I'm understanding is if we then think to the project, and we'll come on and look at this in more detail, you would be proceeding on the basis that for all critical care areas, there's going to be 10 air changes per hour and 10 pascals of positive pressure. Is that correct?
Yes.
Do you ever recall during the time you were working on the project, anyone ever telling you that 10 air changes per hour and 10 pascals of positive pressure would only be provided in isolation rooms and isolation rooms in critical care? It wouldn't be provided for all critical care areas?
No, don't ever recall anyone tell me that.
And if that had ever been raised to say you don't need 10 air changes per hour and 10 pascals of positive pressure for all critical care areas, what would your reaction have been?
My reaction would be to discuss with our technical advisors the implications of that, and for me that would be a non-compliance with the guidance.
In very simple terms, would that be a red flag for you as an estates officer?
If it was brought to my attention in that way, yes.
Now, I think at this point, I want to look at just a couple of project-specific documents, just while we're talking about critical care areas and isolation rooms. At some point during the project, did you become aware of the environmental matrix and the requirements of the guidance notes within the environmental matrix?
I didn't become aware of the guidance notes until after the issue presented itself.
Right.
But I was aware of the environmental matrix throughout my time in the project.
So aware of the environmental matrix throughout. I'm going to come on and look at the guidance notes issues with you. But there comes a point in the project whereby there's problems and you start looking at things like the environmental matrix in greater detail. Is that right?
Yes, correct.
So if we look at one iteration of the environmental matrix, if we could look to bundle 13 and to volume 5, and if we could go to page 922 first, please. So the environmental matrix, it starts on page 921, but the only point I want to take you to is on page 922, and it's right down at the very bottom. The penultimate entry says critical care areas, if we could zoom in on that. Just 3 lines up from the bottom.
Yeah, I can see that. Okay, thanks.
Thank you.
The print's quite small. Can you read that okay?
I can read that, yes. I
Screen?
can read that fine, thank you.
So we see here a guidance note 15, and for critical care areas, it says critical care areas, design criteria -SHTM 0301, Appendix 1 for air change rates, 10 air changes per hour supply. Do you see that?
Yes.
So again, just so I'm understanding things, would that be, in your view, a standard interpretation of table A1 that we've just looked at being translated into the environmental matrix?
Yes.
Now, if we then look on within bundle 13, volume 5, firstly to page 959, this is an iteration of the environmental matrix from the 26th of November 2015. And if we could look down to page 961, please. Again, we'll see environmental matrix guidance notes. If we could look down to guidance note 15, and again looking at the critical care areas. And just as we're doing that, you see that there's some red text being marked up in the guidance notes. Do you see that?
I do see that, yes.
but we don't see any red text being marked up in the critical care areas. Do you see that?
That's correct, yeah. See that?
So in this iteration of the environmental matrix, it says critical care areas, design criteria, SHTM 0301, Appendix 1 for air change rates, 10 air changes per hour, supply for isolation cubicles. Do you see that?
I do, yeah.
Okay. You tell us within your statement that this was never highlighted in red or drawn to your attention when you're working on the project. Is that correct?
That's correct, yeah.
Can you just explain, for those of us that don't work in the space, what's the significance of the change that we see in that guidance note? What would it be telling someone who has knowledge in this area?
Well, what that would do is that it would say that the designers intended only to provide that air change rate to rooms that were classed as isolation rooms. What it also is referring to SHTM 0301 for that guidance, but that's not the appropriate guidance for isolation rooms. So again, it's a change that significantly reduces the number of rooms that would require 10 air changes in critical care and only focuses on isolation rooms.
So again, just so I'm understanding things, the first iteration of guidance note 15 we looked at, your view as an estates officer would be that's what you understand to be a traditional interpretation of table A1 for critical care areas. Is that right?
That's correct, yeah.
And then what we now see in relation to critical care areas simply being 10 air changes per hour supply for isolation cubicles. Is that a different interpretation to what your interpretation of table A1 would be?
Yes.
If that change had been drawn to your attention while you were working on the project, what if anything, would you have done?
I would. Well, again, as I said, I didn't deal with the guidance notes until after the incident. But I would say that had it been brought to my attention, I would query why that change has occurred. The wording is still the same for HDU areas, which is a part of critical care. So why has that specific change occurred in that part of the text? And it would, for me, it would raise a concern that we weren't providing the correct air changes in the entire department.
Now, you said in your evidence there you weren't the person who was really responsible for checking if there's being changes made to the matrix and the guidance notes in particular. Okay. Who within NHS Lothian or out with NHS Lothian, but who on the NHS Lothian side of the project would have had that responsibility?
The primary reviewers would be Mott MacDonald Limited, and they would have advised me or advised the clinical or the project team of any issues they found within the matrix. Your
assumption was that any changes that are being made like this, Mott MacDonald are reviewing them on behalf of NHS Lothian, is that right?
Yeah, well, but with the protocol in place that they should have been flagged as well.
Okay. So there's the protocol that if any changes are being made by the project company, they should be flagged.
Yeah.
But your understanding was also that Mott MacDonald were reviewing them on behalf of NHS Lothian?
Yes, that's correct.
Yeah. And again, just for completeness, the inquiry's considered this before, but Mott MacDonald were, I think, the lead technical advisors to NHS Lothian during the project.
That's correct.
Okay. Within your witness statement, I won't put the reference up, but you describe the fact that this change to guidance note wasn't raised with NHS Lothian. You described that as disappointing. Could you just explain what you mean by that?
Well, again, I think it's as you alluded to, that had they raised that at the time, that would have been this was only version 2, I think, of the matrix, which was immediately after financial close, before my time on the project. But had they raised that at the time with Mott MacDonald, there may have been a different outcome. So I can only assume that perhaps contributed towards the final result.
So again, this might be quite important for the chair, but just to understand matters, we have changes made to guidance note 15, not highlighted in red. And your evidence to the inquiry is that had this been flagged in red and had it been raised with you by Mott MacDonald, you think this is an issue that could have been spotted early on in the project?
Yes.
Okay, thank you. You mentioned that you had an awareness of the environmental matrix while you're working on the project. Now, it's fair to say that the status of that document is a matter of controversy between various core participants. But while you were working on the project, did IHSL, Multiplex or TUV Sud ever describe in any correspondence or discussions you're involved in, did they ever describe the environmental matrix as being a fixed brief given to them by NHS Lothian?
No.
Okay. No. And was your understanding that it was a fixed brief given by NHS Lothian?
No.
Okay. And again, you might not be able to help us in this, but if it was a fixed brief, how could it be that changes are being made by IHSL or their contractors without the knowledge or approval of NHS Lothian? That's
exactly correct. If that was a fixed brief, then they shouldn't be coming back to us with any changes to the document, if that is fixed.
Okay, thank you. I'd like to move on and just look at another piece of guidance. If we could go to Bundle 13, Volume 3, page 464, please. This is a document called SHFN 30, Part B, HAI Scribe, Implementation Strategy and Assessment Process. Do you see that?
Yes.
Is that a document that you were familiar with whenever you were working in your role as an estates officer?
Yes, I was aware of the document, but only in parts, hopefully.
So when you say you're aware of the document in parts, can you just explain firstly what the document is?
Well, it's the infection control implementation for assessing built environment. So it's how we would use it would have been to use it as a tool to examine a project at each various stage to fill in to ensure that we were building it to standard.
Sorry, Mr. Henderson, entirely my fault. I failed to hear the beginning of your answer to the question. You're being asked to explain from your perspective what SHFN 30 is. Could I just ask you to repeat?
Yeah, it's basically a document that we use as a tool to fill in various elements of it at each stage of the project to ensure that we're complying with infection control standards in the document.
Thank you.
So this is a document which you as an estates officer are using as a tool as part of your job?
Yes.
Thank you. If we could look on to page 468, please. You see the first full paragraph there. Scrutiny of this guidance will highlight the frequent use of the word partnership. Successful use of HAI Scribe requires participation and cooperation, particularly between estates and facility staff and infection prevention and control teams. To manage or mitigate the risks highlighted through the use of HAI Scribe requires knowledge from many sources. However, it is not expected that any group will possess full knowledge or experience of another's discipline. It is expected, therefore, that there will be an ongoing liaison during each stage of development where appropriate specialist knowledge from all sources of relevant expertise can be derived and incorporated into the project briefing, contract conditions, specification, and quality control of construction and maintenance. Do you see that?
I do see that, yeah.
Can you just explain in practical terms, what does that concept of partnership working really mean in relation to infection prevention and control in the built environment?
What that would mean is that you would use the pro forma tools within the document to collaboratively agree the mitigations against each of the tasks or highlights in each of the sections. And that should then fulfil the requirements of the preceding paragraphs and text to say this is basically a tool, as I say, to use to get to a point where you're...
and again, in simple terms, is it saying you need lots of people from lots of different disciplines to make sure you build a safe hospital?
Yes.
Thank you. If we could look on to page 469, please. And to the note section in the box, second line down, it states, it is intended as a point of reference for healthcare estates and facility managers, designers, project managers, contractors, engineers, surveyors, health planners, and infection prevention and control teams working on healthcare estate, new build and refurbishment projects. Do you see that?
Yes.
So again, it's not just saying this is a document aimed at clinicians or infection prevention and control is also directed to other disciplines such as estates and engineers.
Yes.
Thank you. If we could look on to page 470, please, into paragraph 1.4. Four lines down in paragraph 1.4, you see a sentence beginning for HAIs to be reduced. So I think that's for healthcare-acquired infections to be reduced. It is imperative that infection prevention and control measures are designed in and IPC risks are designed out at the very outset of the planning and design stages of a healthcare facility, and the input continues up to, into and beyond the final build stage. Do you see that?
Yes.
And then paragraph 1.5, to achieve this, it is necessary that designers, architects, engineers, facility managers and planners work in collaborative partnership with IPC teams, healthcare staff and the users to deliver facilities in which IPC needs have been anticipated, planned and met. Do you see that?
Yes.
So again, is this just back to once again reiterating this concept of a partnership approach to avoid healthcare-acquired infections?
Yes.
Thank you. If we look over the page onto page 471, paragraph 1.6, we'll see the stages of the development. So stage 1 is the proposed site for the development. Then you do a review at stage 2, the design and planning. Stage 3, construction and refurbishment. And then stage 4, pre-handover check, ongoing maintenance and feedback.
Yes.
Again, we'll come on and look at the HAI scribe for the project in greater detail, but am I right in understanding that there wasn't a stage 4 HAI scribe done before the hospital was handed over to NHS Lothian?
That's correct.
Why not?
The issue was at the time was that the hospital had not been fully completed construction-wise. We were entering into, as I understand it, a supplemental agreement to conclude the work that needed to be done. But part of that, and I'm not probably the person to answer this, but part of that, I believe, was that we had to have the hospital handed over to allow the contractor to complete the project.
I think you fairly say in your statement that that wasn't your decision to make.
Yeah, it wasn't, no.
But from your knowledge of SHTM's HAI scribe, which says that you should be doing a stage 4 check before handover, should the inquiry understand that what happened on the project wasn't in compliance with the guidance we're looking at?
Technically, I wouldn't be in compliance, no.
Now, I'd like to look back to a previous set of the SHFN guidance, so still within Bundle 13, Volume 3, if we could go to page 554, please. So you'll see there, this is Scottish Health Facilities Notes 30, version 3, infection control in the built environment, design and planning, bottom right-hand corner. This is the guidance from June 2007.
Yes,
so we've looked at the 2014 guidance, which is really relevant to the project, but presumably if you've worked as an estates officer from 2002, you would have been familiar with the previous iterations of this guidance.
Yes, yeah.
If we look to page 563, paragraph 2.10, about 5 or 6 lines up from the bottom of paragraph 2.10, it states it is therefore intended as a first point of reference on prevention and control of infection for healthcare estates and facilities managers, architects, builders, engineers, surveyors, health planners and infection control teams working on healthcare estate, new build and refurbishment projects. Do you see that?
Yes.
So is that effectively this partnership concept has existed at least since 2007?
Yeah.
And if we look on to page 564, paragraph 2.15, the final sentence there, 3 lines up, beginning much of the solution states much of the solution to the existing HAI problem lies in the effective dissemination and implementation of existing knowledge to all involved in a logical, accessible form. Do you see that?
I see that, yes.
So in many ways, if we just stand back from that, is that simply saying that you need a lot of disciplines and people don't know what they don't know, so you all need to be talking to each other to make sure that you manage healthcare-acquired infections?
Yes, that's correct, yeah.
And was that well understood as at 2007 in the estates community?
Yeah, if I talk to my experience, what we'd normally do is we would sit down initially with infection control and fill in what we could, and then it would be a round the table meeting depending on the complexity of the work to discuss with clinical colleagues and others. But yes, a partnership approach to filling in the required information for the...
Okay. And then if we look on within the guidance to page 568, please. Paragraph 3.10, which states, it is important to consider certain issues before construction work commences, including, and then if we look to the fourth bullet point there, it says the airflow and pressure differentials in the area. Differentials may be varied by external wind strength and direction. And then the next bullet point, the susceptibility of the occupants to infection, e.g. through respiratory problems, immunocompromised or intensive care patients. Do you see that?
Yes.
So even before you get to breaking ground, these are the types of things that you should be considering for a major hospital project.
Yes.
Look on to page 573, please. Section 5, which is risk management. And there's a subheading, identifying risk. And if we could look to paragraph 5.3. 5.3 says, to avoid mistakes and pitfalls, the project team must consider issues including, first bullet point, how will the product, equipment, room or clinic be used? Do you see that?
Yes.
So again, this is the whole project team that should be thinking about this issue, not just infection prevention control, estates, engineers. Everyone needs to have this on their radar. Is that correct?
Yes.
Then if we look to the second last bullet point, what are the standards and guidelines from architectural and engineering bodies, government departments and accrediting agencies? Do you see that?
Yes.
Okay. So again, should the inquiry understand that what the 2007 guidance was telling you was that the whole project team really has to have some knowledge of standards and guidelines issued by engineering bodies, government departments and accrediting agencies?
Yes.
Thank you. If we look over the page onto page 574, we'll see that there's a common errors section. Now that disappears from the 2014 guidance, but we've got common errors that have been identified by 2007, paragraph 5.5. Common errors in design and construction adapted from Carter and Barr 1997 due to inept or non-existent risk management include, and then do you see the second bullet point there says incorrect air turnover and airflow patterns?
Yes, yeah.
So a common error that you can get wrong on a hospital project is your air turnover and airflow patterns.
Yeah.
And did you understand that when you were working on the project?
To be fair, I wouldn't recognise that page. We were using that, as I say, as a tool, which was, there's pro forma sheets that we would use to fill in collaboration with the project team, with the infection control colleagues, and that would be done collaboratively then, and that task itself should mitigate any issues that are in the regular text of the document.
If we just stand back and we'll come on and look at the detail, but one of the issues that the inquiry's got to look at is the fact that there were incorrect air change rates and incorrect pressure cascades in critical care rooms. And that seems to have been a warning that was issued to everyone that's getting the HI scribe guidance from at least 2007 onwards. How did that happen on the project?
I can't speak for how it happened, my apologies, but these documents, this part of the scribe will all have been done before I started on the project, so I can't speak for how that happened on the project at all.
Okay. But do you think whenever we're looking at this particular project, Did the errors in relation to air changes and pressure cascades, did that result from non-existent risk management?
I couldn't, it was all before the time that I started on the project. I couldn't really comment on that.
I want to move on. We've looked at the general guidance, and I want to now look at some of the specifics of the project whenever you're working on it. And I'm going to look at 4 phases, really just to follow the chronology through. So firstly, to look at the point from when the contract signed up to Settlement Agreement 1. Okay.
Yep.
After that, to look at Settlement Agreement 1 itself. Then to consider your involvement in the IOM limited reports. And then finally to consider High Value Change Notice 107 and the period that follows thereafter. So we'll just follow things sequentially through. So in the period after the contract signed, what's your role? What are you doing?
Well, I was brought on in August 2016 as the commissioning manager at Hard FM, and the main part of my role was to ready the spaces in the hospital that we would be occupying as NHS Lothian Hard FM, and the activities that we would be doing as NHS Lothian Hard FM within the site once it was operational, and to agree manpower, budgets, and preventive maintenance, all of these types of things. That was the primary role. The secondary role was to review RDD as it came in, if I had time to do that, bearing in mind that MML were the primary reviewers, but I was able to, using my own kind of experience, to review documents and comment on them as and where I could.
You mentioned that you would be involved in RDD, reviewable design data, but you said if you had time. Was that one of your core functions, or was it something you helped out with?
It became a core function due to the volume of RDD, but my principal role was to, as I say, to ready the hospital and the existing estates workforce at the old children's hospital to come to site.
Okay. So 2016, when you come into the project, you're anticipating not having much to do with the reviewable design data process, but you become more involved as the project goes on.
Yep. Okay. Yeah.
And you say you weren't the primary reviewer of reviewable design data. Who or which entity were the primary reviewers?
That would be MML, Mott MacDonald.
Mott MacDonald. So your understanding working on the project is if there's reviewable design data coming in to be reviewed, it's the lead technical advisors, Mott MacDonald, that are taking that role.
Yeah, and they manage the process as well, on behalf of NHS Lothian.
Brian Curry's working on the project. What's his role at this time?
He's project director, and he's just overseeing everything, the all elements of the project teams. There was a commissioning manager, a lead commissioning manager, Jackie Sainsbury, and underneath her sat the commissioning managers. That was my area. But then Brian had the technical advisor team. He also had project managers working underneath him directly. So then the two parts of that came together under Brian.
Okay. And Janice McKenzie, was she someone that you worked with in the project?
Yes.
What was her role?
She was clinical director.
And what did that involve?
She was the kind of lead on the clinical side. She was a clinical lead effectively for the project. And under her, again, as I say, sat the individual commissioning managers for the specific clinical specialties.
Now, you've talked a little bit about Mott MacDonald and their role that they're leading on the reviewable design data.
Yeah.
But what's your understanding of Mott MacDonald's role in the project when you come into it?
As far as I was aware, they had a project management element. They also had the lead technical advisor element. They had a team of technical people who would review elements of the design. What Mott MacDonald and what others had said to me when they come on, this is a PFI PPP project. It's the design responsibility sits entirely with the project goal. And what they were doing as reviewers was reviewing for operational functionality along with the clinical teams. In other words, ensuring that the spaces, once they were finished, met the requirements of the clinical activity that was taking place in that room, rather than the engineering element.
When you're talking about operational functionality, you're talking about things like clinical adjacencies, is that correct?
Clinical adjacencies, where things were in the room, where the clinical team needed them, where thinking about the ventilation grills directly above the patient head, causing a draft, things like that, rather than specifically the
And
engineer that sat behind it.
are Mott MacDonald, are they undertaking a design review or a design assurance review function for NHS Lothian at this time?
No.
We'll see when we come on to look at quite a few of the documents.
Sorry again, my fault entirely, Mr. Henderson. The question was, Mott MacDonald, were they carrying out a design review or design assurance? And your answer to that is simply no.
No, they weren't. They were reviewing elements of design, Your Lordship, but they weren't primary. There wasn't a shadow design team. They weren't full design reviewers. They didn't have that responsibility.
We'll see when we come on to look at some of the documents, though. Mott MacDonald do seem to comment on areas that go well beyond operational functionality. Was that your understanding?
Yes, it was.
Why were they doing that?
As far as I'm aware, it was where they spotted things that were clearly wrong or clearly an issue. They would highlight that and flag it in the course of their review.
Were they providing, by that I mean Mott MacDonald, were Mott MacDonald providing any advice to NHS Lothian on compliance with published guidance such as SHTM 0301?
Yes, they were. If it were spotted that it was an issue that contravened the guidance or were not in compliance with the guidance, they would identify that if they could.
Okay.
If it was identified, they would highlight to us.
So again, your understanding, we're not asking for a lawyer's definition of the contract with Mott MacDonald, but would your understanding be that Mott MacDonald would be advising NHS Lothian on issues such as pressure regimes and air change rates per hour?
Yes, if that was identified, yeah.
And again, just so we can try and understand, what reliance is NHS Lothian placing on Mott MacDonald at this point in the project?
We are relying on them to advise us if there is an issue that would cause us a risk in the project.
Okay.
Technical risk on the project.
If I could just perhaps bring up a witness statement by one of your former colleagues, Miss Janice Mackenzie. So that's in Witness Bundle Volume 1 at page 151. And if we could look to paragraph 20, please. So there's a paragraph beginning as a result. If we could just perhaps look about 4 lines down, there's a sentence beginning, I am not an engineer. Do you see that about 4 lines down?
Yes, yeah.
So what Ms Mackenzie says is, I'm not an engineer, and it was not my role to know what is required in terms of the technical guidance for every department. That is the role of the engineers and our technical advisors. I would have expected to have been advised either by IHSL directly or via that's her definition of Mott MacDonald, where there were any proposed derogations to technical guidance and specifically what clinical areas and derogations applied to in order to assess the impact of this and be able to discuss this with the clinical leads and IPC and take an informed view. Do you see that?
Yes.
Do you agree with that categorisation by Ms Mackenzie?
Yes, I do, yeah.
Okay. So it wasn't Ms Mackenzie's role to be the expert in the technical guidance. My understanding is that you're saying as an estates officer it wasn't your role to be an expert in the technical guidance.
That's correct, yeah.
In simple terms, was it Mott MacDonald's job?
Of all the parties mentioned, yes, it would have been.
Now, in the period after the contract's signed, there still seems to be quite a lot of work that is going on, a very large volume of reviewable design data. Was that your experience when you started working on the project?
It was, yeah. I was surprised to learn that there was still so much design left to do in the project, given that its initial completion date was July 2017, and we're in August 2016 at this point.
And what were some of the challenges that presented to NHS Lothian and their project team?
Well, it was hard copy documents that you were reviewing, and there were bundles and bundles coming at a time with a turnover time of 15 days. As I say, I don't think we didn't employ Mott MacDonald as a shadow design team, so we didn't have a team of designers sitting ready to receive that information and process it in the time frame required. We were only doing reviews for operational functionality, but obviously if something was spotted within the information that we were provided with, we would review that and comment on it. So it was a lot of information to turn over.
And you cover this in your statement. There's a lot of information coming in. There's a lot of changes being made that have to be reviewed, albeit you say the only responsibility, as you understood it on NHS Lothian's side, was to check for issues of operational functionality. But there's a lot of changes being made. One thing I'd be interested in your views on, Mr. Henderson, is in relation to the changes that are being made, when you come into the project, did you think there was really a fixed brief, a fixed set of requirements that NHS Lothian had specified, or were the requirements changing as the project went on?
No, I wasn't aware that the requirements changing as the project went on. I think that when I came on, I expected that the brief was fixed. It was everything was settled. That yes, there are always changes as things go on in projects, but the level of change is something that may not be consequential.
So your understanding is that NHS Lothian had fixed what their requirements were, and that this was now really a discussion about how the designers were going to implement that.
Yes, I'm hopefully trying to be kind of careful when I say that there, but obviously the fixed part of it, the elements were that it was Project Co's responsibility to do the design. They were to take the documents at a certain stage and develop them into a full design. So the fixed part was that we'd given over documents for them to adopt and change, alter, review, amend to meet compliance and ensure it was compliant and provide us with a compliant hospital.
If we just perhaps look at some of the documents in relation to trying to understand Mott MacDonald's role in the project. If we could look to volume 13, bundle 2, to page 538, please. So volume 13, bundle 2, page 538. So this should be an email from Kelly Bain of Mott MacDonald on the 19th of May 2016 to Darren Pike of Brookfield Multiplex and a range of other people. And it states, "Hi all, the board have noted the number of air changes within the en-suites is higher than that required under SHTM." Do you see that?
Yes.
Again, if all that NHS Lothian had responsibility for was operational functionality, why do we see NHS Lothian's lead technical advisors feeding back to Mott MacDonald that they're not complying with the technical guidance?
I wasn't, it was just prior to my start on the project, but I can only assume at that time that the reviewer had spotted an issue around the air change rates in the en-suites and wished to raise it. And there may be a point there against the BCRs where we were to maximise heat recovery from the system, so there's an opportunity there for heat recovery that wasn't taken.
Okay. If we could then look to bundle 13, volume 1, please. And to page 7. Bundle 13, volume 1, page 7. This is an email from Camille Kowajczyk to Ken Hall of Multiplex, copying in various other people from the 17th of October 2016. Again, it states, "The board have reviewed the environmental matrix and still has significant concerns on items that do not appear to comply with the BCRs." Do you see that, the board construction requirements? Then if we look to point 6, it states some ventilation rates don't appear to comply with BCRs. So whenever you come into the project, was that a real concern that NHS Lothian had in terms of the content of the environmental matrix and its compliance with the standards that NHS Lothian was expecting?
It wasn't initially apparent to me, no, and it didn't really become apparent until later on. The environmental matrix was a document that was a large, I think others have said it, a large piece of information that was difficult to review in its entirety. And as I understand it, MOTS were doing sample reviews on the document, and where they identified discrepancies or errors, they were raising comments with it. But it was never ever raised to me that it was a massive issue during my kind of early part of the project, but obviously it later became so.
So sample reviews that are taking place, issues being identified and fed back.
Yes, yeah.
And if we look on just to page 8, please, you'll see the final paragraph. Whilst the board has noted general and specific comments above, the board reminds Project Co that unless the board has already accepted a derogation, it is Project Co's obligation to comply with the BCR/SHTMs, etc., and the board not commenting does not remove that obligation on Project Co. Do you see that?
Yes.
So again, just so I'm understanding things, is that whenever you say this is a revenue-funded project with a project company that's taking all of the design responsibility, well, there might be comments coming back from NHS Lothian, that's not shifting the design responsibility as you understand things?
Correct, that's exactly how I understand it, yes.
Having looked at some of those documents involving Malton McDonald, I'd really just like to try and sketch out a timeline of your involvement within the project. And if we could maybe begin by looking to Bundle 13, Volume 8, and to page 2340. So Bundle 13, Volume 8, page 2340. Just while the documents are being located for, I'm conscious that we're slightly after 11:30, but given the stoppage, would your intention be simply to proceed?
I think let's try and make up time.
Thank you.
Yeah.
So Bundle 13, Volume 8, page 2340, document headed up NHS Lothian, RHSC, DCN, Edinburgh, HV issues, 19th June 2016, Health Facilities Scotland. Health Facilities Scotland were contacted by NHS Lothian via telephone call on Tuesday 13th June 2016 to request a review of the high voltage installation at the Royal Hospital for Sick Children in Edinburgh. Do you see that?
Yes.
Were you working on the project at this point?
I was working on the project at the time of this because these dates are wrong, unfortunately. HFS have put the wrong dates on their document. It was actually 2017.
Okay, so whenever we see this date here as 2016, your understanding is that actually it's 2017?
Yeah, it was, yeah.
So if we look down to page 2344 into paragraph 2.5, we see that there's a range of issues that HFS are asked to comment on. But at 2.5 at the bottom of the page, this note records, what is Health Facilities Scotland's interpretation of the ventilation pressure requirements for 4-bed wards? Do you see that?
Yes, I do, yeah.
So is that something you'd asked HFS for advice about?
I did, yeah.
Okay. What they record is in the 3 bullet points on page 2344 onto 2345. SHTM 0301 Part A, Appendix 1, Table A, indicates the air change rates and pressure regime for clinical areas within healthcare premises. There is no 4-bed ward noted in Table A. However, it would not be unreasonable to treat this area as one would a single-bed ward with respect to ventilation, as the measures for infection control would be the same. Therefore, the room should be neutral or slightly negative with respect to the corridor. SHTM 0301 Part A clause 1.35 et al. Details the management action, with clause 1.37 highlighting the need to seek guidance from clinical colleagues. And then finally, SHTM 0301 Part A, clause 1.39 et al. Details the design and validation process. Table 2 highlights the model to be followed, and item 2 outlines some of the design questions to be asked and resolved. Do you see that?
Yes.
So effectively, the guidance being provided for 4-bed wards is that it should be neutral or slightly negative pressure. And there's reference to clause 1.37, which we looked at previously, which said you really need to defer to clinical colleagues in relation to what they want to do with the space.
Yes.
There's nothing recorded here from HFS that indicates you really need to consider whether you're dealing with a 4-bed ward in critical care, is there?
No.
Okay. Why were HFS not asked to provide advice on that specific issue?
I think that what had happened in this case was that the clinical teams had already met and decided that they needed these rooms to be balanced or slightly negative to the corridor. It was presented as a schedule of 20 rooms, basically, that needed to be balanced or slightly negative, and the question was then posed to HFS. The clinical need is that, what are your views?
So effectively, just so I'm understanding, when you come into the project, your understanding is the clinicians tell you as the estates officer, there's 20 rooms that we need to have as balanced or negative pressure. Some of those are 4-bed wards, and you then contact HFS for advice on that.
Yeah.
So at that point, at the point you're contacting HFS, are you aware of whether any of these 20 rooms are in critical care?
No.
Okay. If you had been aware of that, would you have escalated that to HFS?
It's difficult to say. At the time, this was a specific narrow requirement to have 20 rooms at balanced pressure or slightly negative pressure. So it is unfortunate, but the dots weren't joined. So I would have, had it been brought to my attention explicitly that there was an issue with those because they were in critical care, then yes, I would have escalated it to HFS. But no one, McDonald, IHSL or anyone raised specifically anything about critical care.
So you say that the dots weren't joined, and that really seems to be key, because is that not really what all the published guidance we've looked at has said, that you need all of the disciplines so that the dots can be joined? So why weren't the dots joined in this project?
Again, in this specific item here, I can only say that it was a very narrow requirement, and the clinical team had met, the clinical team had established their requirements and stated them to us that, or stated them to IHSL, basically, that we wanted that these rooms to be balanced or slightly negative. And it wasn't a want, this was a compliance issue, and we sought advice from HFS on that regard. It just so happened that unfortunately 4 of the rooms were in critical care.
But the clinicians not told you that some of these rooms were in critical care?
If it was mentioned specifically, then it missed.
Well, if we maybe just look through, in fairness to you, it's a long time ago, some of the correspondence, it might help jog your memory. So if we looked firstly to Bundle 13, Volume 7, at page 37.
Thank you.
And if we could start with the email towards the bottom of the page, the one from the 20th of January 2017, timed at 12:53. So this is an email from you to Jeanette Richards. Who was Jeanette Richards and what was her role in the project?
She was the project IPCN nurse, basically. So she was within the project she would meet to discuss IPC issues with. Yeah.
Jeanette Richards, in terms of the partnership model, is providing the infection prevention and control role, and you're providing the estates role. Is that correct? Okay. So you see the email from the 20th of January. Hi, Jeanette. That's just it. It doesn't. There's some dubiety over a couple of things. 1, can a 4-bed bay be described as a general ward? 2, if so, what is the pressure relationship to the corridor, as there's just a dash in the box to the table you attach? I'm looking for infection control's take on a scenario such as if 4 patients with infection status unknown are in the room. What way do you want the air to go? To the room from the corridor, or to the corridor from the room? Do you see that?
Yes.
So is this effectively some of the discussions you're having before you contact HFS?
Yes.
There's rooms, 4-bedded rooms. There's no specific guidance for 4-bedded rooms, and you're trying to work out what you should be doing.
Yeah.
And you're saying specifically to infection prevention and control, to prevent infection, what pressure regime do you want?
Yes.
And if we look just slightly up, we see Jeanette Richards' response to you on the 23rd of January 2017 at 9:25. So it's bundle 13, page 37 at the top. Dear Ronnie, the 4-bedded rooms are considered to be the general ward. As you're aware, each 4-bedded ward has an ensuite toilet, negative extract, and an ensuite shower, negative extract. Should we get to the scenario that all sink cubicles are full and we have 4 cohorted patients in a 4-bedded bay, then yes, we would want to ensure all infectious organisms are maintained in the room, which yes shows that neg pressure in the 4-bedded area is of benefit. Our contact at Mott MacDonald will probably be able to advise, as will Ian Storer at HFS, if this communication is not clear enough. Do you see that?
Yes.
Okay. If we just pick through a few things, you're being told here, firstly, the 4-bedded rooms are to be considered as a general ward. Is that right?
Yeah, again, that's an interpretation from the infection control nurse.
So you're not being told in this communication that it's going to be a critical care area or an isolation unit or anything like that. Okay. You're also being told that each 4-bedded bay has an ensuite toilet. Is that of any significance in relation to the published guidance?
It isn't in respect of critical care, because critical care did not have ensuite toilets in any of the rooms.
Again, just so I'm understanding things, if this had simply said 4-bedded rooms won't have an ensuite, would that have had relevance to you, given your knowledge of the guidance?
It's difficult to pick up on whether that would have been the case at the time. Obviously, retrospectively looking at it, it would have definitely, but I can't say for certain at the time if that would have had relevance. But all that we can see from that is that the ensuite toilet was the means by which the air would be extracted from the room to provide the pressure regime, and that would be classed as dirty extract. So it wasn't in the patient bedroom, it was in the toilet or the ensuite or the shower room.
But your understanding is that any space within critical care, 4-bedded ward, for example, in critical care, it wouldn't have an ensuite, so you couldn't extract ventilate that way?
You couldn't, yeah.
Thank you. If I can ask you to look within Bundle 13, Volume 1. We go to page 21, please. So this is an email of the 9th of February 2017 from Brian Rutherford of Wallace Whittle. It's a range of people, including you see yourself, you're copied in just as the second last entry. So it's Bundle 13, Volume 1, at page 21. See that? So it's an email from Brian Rutherford to Stuart McKechnie and others. You're named in the recipients just as the second last entry before Dorothy Henley. And the subject's multi-bedroom ductwork amendment proposal. It says, all further to our ventilation workshop on Monday, please find enclosed a copy of our multi-bedrooms ventilation amendment proposal to achieve room balance. Proposed solution to rooms identified as being of concern. As agreed, we have also enclosed a set of A3 general arrangement layout drawings to be used as key plans overmarked to show specific room locations. Do you see that?
Yes.
So why was this email being sent at this time?
I think from looking at the timing of that was when we were beginning to discuss 4-bedroom ventilation being a concern, that it wasn't balanced at the door, and we'd asked Multiplex or we'd asked Project Go to provide a solution to make them balanced at the door, and this was the next step from that.
So at this point in time, there's effectively a dispute between, on the one side, NHS Lothian, and on the other side, project company and their advisors, as to what pressure regime there should be in various spaces. Is that right?
Yes.
Okay. Then we'll come on and look at later documentation about the rooms, what they're going to be used for. But at this stage, is it really just as simple as a dispute over whether 4 bedded rooms, the 20 rooms identified, should have balanced or negative pressure or positive pressure?
Yes. Yeah.
If we still just stay within Bundle 13, Volume 1, if we looked at page 22, see there's a set of plans marked up pointing to A, B and C. Do you see that?
Yeah, I see that, yeah.
Then if we look on to the next set of plans, we'll see them on page 23 marked up as D, E and F.
Yep.
And then on page 24, we'll see them marked up as G, H, I, J, K and L.
Yes.
Do you see that?
Yeah.
So specifically, the author of the email is highlighting where the rooms are that are in dispute between the parties. Is that right?
Yeah.
If we just look down onto page 25, we'll see that there's a TUV SUD multi-bed rooms ventilation amendment proposal to achieve room balance. Do you see that?
Yes.
Okay. So if we just take some examples that were circled as A to I. If we look at D, do we see the room number there is 1B1063?
Yes, yeah.
You tell us in the statement at the time those codes didn't mean anything to you. Have you subsequently found out what the code B1 means?
Yes, yeah.
What does the code B1 mean?
That's the critical care area.
Okay. And we'll see that code B1 cropping up for letter E, which is B1031, over the page onto F. So this is page 26, letter F, B1-009. Do you see that?
Yeah, see that, yeah.
So at this point in time, is it fair to say you get an email from Mr. Rutherford on the 9th of February. There's a series of plans with giant red arrows pointing to the spaces in the building, is that right?
Yes, from the drawing there, yes.
And you've got a table that comes with it, with the codes B1, albeit at this point in time you don't understand what the code B1 means.
Yes.
At this point in time, so we're into 2017, have you seen multiple iterations of the environmental matrix by this point?
I've probably seen it, but I couldn't tell you how many iterations I had seen of it. I don't know when the versions came out.
But you would have seen the environmental matrix?
Yes.
Because you said part of your role, and it became an increasing role, was that you were involved in reviewable design data, which would include iterations of the environmental matrix.
I will say I didn't review the environmental matrix. That was left with McDonald. It was a document that I wasn't familiar with, and it was significantly in size that I didn't review it.
If we just perhaps look, we'll come back to that document we're looking at, but if we just look to the environmental matrix, so for example, if we look to Bundle 13, Volume 1 and page 67, do we see here in the environmental matrix, there's a big box, left-hand box, is depth code, department code, do you see that?
Yes, I do, yeah.
And then there's an index, and if we look down, we'll see that B1 is critical care / HDU / neonatal surgery. Do you see that?
Yeah, yes, yeah.
If we maybe just look back to that email we were looking at a moment ago, page 21. At this point in time, 9th of February 2017, Mr. Rutherford is contacting Camille Kowajczyk of Mott MacDonald, Brian Curry of NHS Lothian, Colin McRae, who's an engineer from Mott MacDonald that the inquiry's heard evidence from before, yourself on NHS Lothian, and Dorothy Henley at NHS Lothian. And included with that is the TUV SUD multi-bed rooms ventilation amendment proposal that includes these codes B1,
Yes.
but no one on that email chain is picking up on the fact that some of these rooms are in critical care. Is that right?
I can't speak for others, but I certainly didn't.
Is this one of those issues that you would have expected Mott MacDonald as your lead technical advisors to be picking up on?
I would say so, yes.
If we could look on, still within Bundle 13, Volume 1. If we could look to page 34, please. See, this is a note of a meeting that takes place on the 24th of February 2017. Do you see that?
Yes, I do, yeah.
And it's called Bedroom Ventilation Update Meeting. There's a range of attendees. So the second attendee is Janice McKenzie, who is the infection prevention or I think the clinical director for the project. Is that right?
Yes, yeah.
We see that number 3 is Dorothy Hanley, who's the commissioner involved in commissioning. 4 is Brian Curry. We then see number 7 is Camille Kowajczyk from Mott MacDonald. And then you also attend your number 8, is that right?
That's correct.
And can you remember what was this meeting about? What's being discussed on the 24th of February?
I think this may have been the second meeting subsequent to the initial raising of the issue around 4-bed ventilation. And I think at that meeting, the clinicians tabled the rooms that they required to be balanced. I think there was a total of 20 multi-bed rooms in the facility, and some of these were deemed to be essential for balanced or negative, and others were deemed to be desirable but not essential. And that was, I think this was a meeting that set those 14, I think it became ultimately 14 rooms as essential.
Sorry, again, 14 rooms.
14 of the 20, I think, yeah. I'm trying to think of the timing of it. I don't have the actual record of the meeting there, but I think that meeting there was the one that decided that it would be.
And if we just think back to the partnership model right at the start, we've got here clinicians, estates, project manager, and engineers, is that right?
That's correct, yeah.
But is one discipline that we don't see here is infection prevention and control?
I think, and I can't speak for Janice, but I think infection prevention control had been consulted in the process leading up to the decision to name the rooms, or to not name the rooms, but to identify the rooms that required it. They may not have been at that meeting, but they were in the process.
And if we look on to page 35, we see that this is marked up at meeting 24th of February 2017, General Ward Ventilation Amendment Proposal to Achieve Room Balance. Do you see that?
Yes.
And there's various rooms that there's handwritten comments saying essential, essential, essential. Do you see that?
Yes, I see that.
So we see D, which is one of the rooms with the code B1. It's essential to have balanced and negative pressure, is that right?
Yes.
Okay. E again, which has got the B1 code, it's essential to have balanced or negative pressure.
Yeah.
F, which is again got the B1 code, it's essential that it has balanced or negative pressure. And then if we look on to page 36 to M, you see the entry there for M, again, yes. G1065, it's essential that it is balanced or negative pressure. How was a judgment being made at this meeting in terms of which rooms it was essential to have balanced or negative pressure for?
It was a clinical requirement to cohort patients, and the need to cohort patients in these rooms meant that they needed a specific pressure regime to prevent the spread of infection out with the room. And these were the rooms that were all deemed to be locations where they would cohort patients.
Okay. So was there discussion at this meeting that there had to be cohorting of patients? Is that right?
I don't recall specifically that. I think this was the meeting where the decision had already been made about cohorting of patients. That was a clinical discussion that happened prior to this, and this was the meeting where the rooms that were identified that needed to cohort patients
And was there any discussion as to what area of the hospital they'd have to be cohorted in?
No, there was no discussion at that meeting that I recall.
So there's a meeting to decide which rooms it's essential to have balanced or negative pressure in, but there's no consideration given whatsoever to whether those spaces are in critical care.
I can only speak for myself, but my view on this was it was a very narrow focus. It was the pressure regime for these 14 rooms was required to be balanced or slightly negative. And at that point, it didn't register or connect that some of these rooms were in critical care.
So again, if I can just understand this, your understanding is that the decision has been made that it has to be balanced or negative pressure. Is that right?
The clinical requirement has been assessed that these need to be balanced or slightly negative, yeah. Decisions different as
so
clinical
again,
decision, yeah.
just so I'm understanding this, are you saying that effectively the clinicians had said we need balanced or negative pressure,
yeah,
and you interpreted it that your job was simply to deliver balanced or negative pressure?
Yes.
We think back to that partnership model about you don't just have the clinicians making clinical decisions, you don't just have infection prevention control making infection prevention control decisions, you don't just have the engineers working in silo. Do you think that partnership model had broken down if the clinicians had simply said what had to happen with the space?
No, I don't. I think there were several meetings around with partners, certainly with infection control as well, and they came up with a clinical need for a space, and that was communicated to all those people that you mentioned in the partnership, the designers ourselves. But designers were a separate entity, so we take that to designers in these forums that we're looking at here. And they were required to, or requested to deliver it, and there was a dispute over who was responsible for delivering it, or paying for the delivery of it. But as I say, it was a narrow focus for me specifically, and I'm sorry I keep mentioning that, but for specifically I was looking at the pressure only, the schedule being the document for the pressures only.
But your recollection is that at this meeting there's no discussion whatsoever taking place that some of these rooms are in critical care?
No.
We can move on and look at the general risk assessment that was completed in July 2017. So if we could begin at Bundle 13, Volume 8, page 449, please. Bundle 13, Volume 8, page 449. And if we could start with the email towards the bottom of the page. This is the email of the 6th of July 2017 at 17:16. So this is from Janice McKenzie to Jackie Sandberg and Brian Curry. You're copied into this email, as is Kelly Bain of Mott MacDonald, Camille Coward-Jacek from Mott MacDonald, and Graham Greer, who is also of Mott MacDonald. And the subject is risk assessment re 4-bedded room ventilation. It says, Dear both, please find the clinical risk assessment in relation to the above as requested, which Dorothy, Fiona and I have pulled together. The issue only really affects children's services, but we have discussed with Hester. Do you understand what Hester means?
Hester Niven she was the clinical lead for DCN, Department of Clinical Neurosciences.
Okay, so discussion with clinical neurosciences as well.
Yep.
The email continues, we consulted with children's CMT representatives this morning, Fiona Mitchell, Eddie Doyle, Linda Cowie, Peter Campbell and Sharon Russell, and the risk assessment fully reflects their views. So effectively, a wide range of clinicians have had input into this risk assessment, is that right?
Yes, yeah.
It continues, they are clear, as we also are, that we cannot have a new facility that does not give us the option of cohorting patients with airborne infections. So is that really the clinical need that you talked about, this idea that you simply, the clinicians are saying we must be able to cohort patients in these four-bedded bays?
Yes.
It continues, we have suggested an overall compromise position of only some of the 4-bedded rooms in the facility having the ventilation changed. In summary, all in PARU and medical inpatients, and one of the 4-bedded areas in critical care. Do you see that?
Yes, I do, yeah.
Is this not Janice McKenzie specifically flagging up that at least one of these rooms is going to be in critical care?
It appears that, yes.
So again, we just think back to the project. We're in July 2017. We've got infection prevention control, project manager Mr. Curry, yourself as the estates officer, 3 individuals from Mott MacDonald, the lead technical advisor, Miss McKenzie saying at least one of these rooms is going to be in critical care. But still at this point in the project, nobody involved in the partnership approach is picking up on the significance of that in terms of the ventilation pressure regime.
That's correct.
How does that happen?
I can't explain that. I mean, as I say, unfortunately, the dots weren't joined, and I can't explain why. I get, from my own point of view, and I'll repeat it again, is that a very narrow focus. The clinical need was these requirements to have balanced or negative pressure to prevent the spread of infection, and that was the means by which I carried out my reviews of the schedule of rooms only.
It does seem quite troubling that the guidance talks about the need for the partnership approach, and it doesn't pin down one limb of the partnership that takes overall responsibility. It says infection prevention and control, they need to know about the guidance and the engineering requirements. It says the exact same for the contractors, the engineers, the clinicians. How does it come to be that this partnership model broke down?
Well, I mean, you did mention one of the parties in that. Obviously, the contractors have a responsibility in this as well. They are the designers. They should have been highlighting to us, in my view, that you do realise that some of these rooms are in critical care and there are separate requirements for critical care spaces and the ventilation guidance. None of that occurred. Nobody in my time in the project anyway took out critical care as a separate entity and said, let's have a look at critical care's ventilation requirements, sit down and decide, do they meet guidance? Nobody done that, as they done for haematology and oncology or for the single bed ventilation issue 64. These were treated as separate blocks of review, discussion and agreement, or tacit agreement anyway, because we didn't agree on anything. Obviously it was the designers to design it. That never happened for critical care. So,
and if we just perhaps stand back from matters, in terms of this issue, for this project, are we really talking about isolated errors where in this specific project this was missed? Or in your view, really, is there a problem with the partnership model, that the model itself simply isn't working?
if you talk about partnership model and its completeness, including the contractor and the special purpose vehicle in it, yes, that clearly didn't work in this case here.
It's just in terms of Miss McKenzie's email, we don't see the contractors being copied in. Do you know if they were provided with a copy of the risk assessment we'll go on to look at?
I don't know for certain if they were or not. Couldn't say.
So was your understanding that they were labouring under the same misapprehension you were, that simply there must be balanced or negative pressure and there's no discussion of critical care rooms?
I can't speak for them in that regard.
Okay. If we just perhaps...
Sorry.
No, please do go on.
Because the starting point was different for both parties as well.
Thank you. If we just return to the email, so we're still in Bundle 13, Volume 8, page 449. And I just read to the bit critical care. And it continues, critical care. However, the Children's CMT did say that to achieve this, there would be a delay to programme. And then they questioned whether we should not be changing all of the 4-bedded rooms to allow for future proofing and flexibility. Do you see that?
Yes.
It's effectively in this email saying one room, one 4-bedded bay in critical care must have balanced or negative pressure, but the clinicians would really like it to be all of them. Is that right?
Yes, yes.
And then it continues, next paragraph, infection control have also confirmed they are happy with our risk assessment. Do you see that? So again, infection prevention and control, look at the risk assessment, they're not flagging any issues, is that right?
Correct.
At this point in the chain, in July 2017, this is whenever the risk assessment's being done, this is after the meeting has taken place to agree what the essential rooms are. Is that right?
The timescale would seem to fit with what you're describing. Yeah, it was perhaps done as a formal way of acknowledging the rooms that were to be done.
It's just, again, to an outsider looking, it might seem odd that you agree what rooms you have to have balanced and negative pressure for and then do the risk assessment. Why wasn't it the other way around?
I couldn't speak for my clinical colleagues that they'd done it that way.
But in terms of your involvement as an estates officer, would you not expect the risk assessment to be done before you agreed what rooms it was essential to have a particular ventilation regime for?
I would have liked to have had all the documentation in place, but I can't specifically recall at the time why we came to the view that we had the information to hand to proceed with that on that basis.
If we look onto the next page, so Bundle 13, Volume 8, we're now into page 451, which is the risk assessment that's attached to the email we've just looked at. Headed up Record of General Risk Assessment, and you'll see in the top right-hand corner, it's completed on the 5th of July 2017. And then it says, subject of assessment, consider task or environment. It states bedroom ventilation design in 4-bedded rooms does not meet the recommendations of SHTM 0301 as the current design has the 4-bedded rooms as being positive pressure. Do you see that?
Yes.
Again, the inquiry will hear from Ms Mackenzie in due course, but would she be able to make an assessment of whether there's compliance with SHTM 0301? Because as I understand it, her position is she wasn't an engineer and she couldn't really make those judgments.
By that time, we would have had the view from HFS prior to this. So the view was that the way that they had designed it, using the general board categorisation from Table A1, wasn't in compliance with SHTM 0301.
So this is guidance from HFS when HFS weren't told that any of the spaces were in critical care, is that right?
Yes, you're right, yeah.
Thank you. So if we just return to that box, it says, to allow cohorting of patients with the same airborne infections, these rooms require to be balanced or negative pressure. Do you see that?
Yes.
So again, clear risk assessment with the clinicians saying, from a clinical perspective, we need balanced or negative pressure, is that right?
Yes.
We skip the next paragraph, and then the final paragraph in that box states, the risk assessments have been discussed with children's CMT and infection prevention who have confirmed that not having the ability to cohort patients is not acceptable from a patient safety perspective. In addition, the children's CMT highlighted that if the programme is going to be delayed in order to achieve compliance with the SHTM 0301 in the 4-bedded rooms, then should we not be considering achieving this in all 4-bedded rooms, which is what we've already seen in the email that accompanied it. So yes. Both infection prevention control and the clinicians are saying this is exactly what we need, balanced or negative pressure.
Yeah.
And we see step 1 in the next box, the overall risks. And one of the overall risks is the inability to cohort patients with airborne infections in a clinically safe environment. Do you see that?
Yes.
That's effectively the clinical requirement that you would be told about as an estate.
Yes. Yeah.
Then after the bullet points, it says, see separate risk assessments for inpatient wards as the risk rating for each ward is different dependent upon the patient group and clinical risk. Do you see that?
Yes, yeah.
So that would be telling anyone that read that there's different categories of patient and different risk assessments for each of them. Is that fair?
Yes.
And then step 2, it says specifically, see risk assessments for specific wards. Do you see that?
Yes, yeah.
And then at the bottom, there's a summary of risks by wards. Do you see that?
Yes, I do, yeah.
And the third entry there is RHCYP-critical care with the proposed action 1 4-bedded room B1063 ventilation change. Do you see that?
Yes.
So highlighting that certainly the individuals that created the risk assessment were fully aware that at least one of their 4-bedded rooms was going to be in critical care.
I see that, yes.
If we look on to page 455, please. This is still within the record of general risk assessment. You see that the department there, so the third box down, the department, RHSC and DCN re-provision project, RHCYP critical care B1. Do you see that?
Yes.
So again, anyone that's reading this document would see that there's a specific risk assessment being undertaken for critical care, with critical care being given the short code B1. Do you see that?
Yes.
It continues, subject of assessment, consider task or environment, ability to cohort patients within critical care unit, and then step 1, what are the hazards? Clinical risk is still relatively high if no cohort area available, and therefore operationally to retain the ability to cohort within B1063 low acuity HDU would be clinically and operationally highly advantageous. Do you see that?
Yes, I do.
So that's the justification and the hazards being set out. Step 3, what are you already doing? Existing precautions. And then there's critical care B1, 24 beds. See that?
Yes, yeah. Your boss want to take a toilet break soon?
Absolutely.
Certainly.
Okay. Okay.
Perhaps, Lord Burley, just to say to any core participants, I'm going to go on and look at the second risk assessment. It may sometimes be helpful to have the two side by side. There's some copies at the front, if anybody wants, so they can have one up on their screen and one paper copy. There is paper copies for anyone who'd like that.
Mr. McGregor.
Thanks.
Thank you. I was just going to move on and look at a second refreshed record of general risk assessment. So if we could have bundle 6, page 14, please.
Again, David, I'm okay.
So you see in the top right-hand corner, date of original assessment, 5th of June 2017, reviewed 29th January 2018. Do you see that?
Yes, yeah.
Do you have any recollection of seeing this refreshed record of general risk assessment when you were working on the project?
I don't have specific recollection of it. I do know that there was these were produced, but I don't have a specific recollection of reviewing that document.
Do you think it's likely that you would be provided with a copy, or was this simply something that would be refreshed by the clinicians?
I would probably be provided with a copy of it at some point.
We just look through this. There's some similarities, some changes that take place. So in the scope of subject of assessment, consider task or environment, still says bedroom ventilation in 4-bedded rooms did not meet the recommendations of SHTM 0301, as the current design has the 4-bedded rooms as being positive pressure. Do you see that?
Yes.
So it's still, by the time we're in January 2018, none of those dots have been joined, I think you talked about. Is that correct?
Yes.
Okay. This time it says in bold, to allow cohorting of patients with the same airborne infections, these rooms required to be balanced or negative pressure. Do you see that?
Yes.
And if we look to the penultimate paragraph, about 4 lines up, or 3 lines up, it says risk assessments highlight that it is essential, do you see that in bold, essential,
Yeah.
to change the ventilation in 7 of the 4-bedded rooms within RHCYP. It would be desirable, in bold, to change the ventilation in 6 of the 4-bedded rooms in the RHCYP. You see that?
Yes. Yeah.
And then the next paragraph, the risk assessments have been discussed with the Children's CMT and Infection Control and Prevention, who've confirmed that not having the ability to cohort patients is not acceptable from a patient safety perspective. Do you see that?
Yes.
So again, just so I'm understanding the things, the clinicians are still saying they need to cohort patients, and that is critical in terms of patient safety.
Yes.
Again, there's references to the various risk assessments that need to be completed, but if we look to the box at the very bottom, so bundle 6, page 14, very bottom of the page. See the final entry there is RHCYP critical care, and the proposed action is 1 4-bedded room, low acuity HDU B1, and then over the page 063, and 3-bedded room surgical neonates B1065. And then in summary of risks by wards desirable to have ventilation changed, we see the RHCYP critical care, 4-bedded rooms critical care, B1-009. Do you see that?
Yes. Yeah.
And then in the next box, summary of risk by wards, the second box, RHCYP critical care, no change to high acuity 4-bedded room B1-031. Do you see that?
Yes.
So again, references to critical care. We then look on to page 18, please. The department's given us RHSC and DCN reprovision project, RHCYP critical care B1, subject of assessment to consider the task or environment, ability to cohort patients within the critical care unit. Step 1, what are the hazards? Clinical risk is still relatively high if no cohort area available, and therefore operationally to retain the ability to cohort within B1063 low acuity HDU and B1065 surgical neonates is essential, and it would be clinically and operationally desirable for B1-009 intensive care. Do you see that?
Yes.
And then below that at step 3, we see critical care B1, 24 beds, 1 times 4-bedded rooms, low acuity, and 2 times 4-bedded bays, intensive care and high acuity. Do you see that?
Yes. Yeah.
So at this point in time, by the time we've moved to January 2018, the clinicians are now saying that there's 4 rooms in critical care that must have balanced or negative pressure. Is that right?
I think I mean that is. Yeah. I see. Yeah. Yeah.
Yeah. And again, this isn't something that you spot. Is it something that you remember Mott MacDonald raising?
No. No.
I could ask you to, if we move on in the timeline, so to the 1st of February 2018, if I could ask you to have in front of you, please, Bundle 13, Volume 5, page 1243. So this is an email chain that you're not copied into, but it begins with Janice McKenzie emailing Dorothy Henley, copying in Graham Greer of Mott MacDonald and Brian Curry, the project manager. Bundle 13, Volume 5, page 1243. It's an email from the 1st of February. You see that the second email is an email from Dorothy Henley to Janice McKenzie, copying in Graham Greer and Brian Curry. And she states, my comments and additions of rationale column for Janice's additions stroke amendments. Do you see that?
Yes.
Now, you're not copied into this email chain, but what it does include, if you look on to page 1244, is it's a Mott MacDonald logo document, if you see that in the top left-hand corner. And if we zoom in at the top, it's called RHSC and DCN multi-bedroom -4 beds ventilation extracts from the IHSL environmental matrix. And then below that it says this tracker has been collated using information provided in IHSL's environmental matrix. The tracker is intended as a collated reference document for the key ventilation parameters for the multi-bed rooms -4 beds. Do you see that?
Yes.
Now, if we think back to what you told the inquiry at the start of your evidence about Mott MacDonald are involved in the project, they're the lead technical advisor, but all of the design risk sits with project company.
Yeah.
And there's just a sort of light touch sampling review that's being undertaken by Mott MacDonald. And if they're lucky enough to spot any discrepancies, that would be fed back. That's some of the emails we looked at the start. We now seem to be in a scenario in early 2018 where Mott MacDonald are making up tracker documents relating to pressure and air change regimes in 4-bedded rooms. Is that fair?
Yes. Yeah.
What's happened between that original light touch sampling approach and the point in 2018 whereby we've got this Mott MacDonald headed document that's setting out a whole host of technical environmental parameters? Has their role changed?
No, there's no role change. I can only assume, and this document's not familiar to me, I don't know if I review it in the email chain, but I can only assume that it was in order to keep track of the schedule, the comparative schedule or comparator schedule that Project Co were producing of the 20 rooms, the one you had up earlier, where they had overmarked essential on it. That would have been a tracker to keep track of that room by room. But I'm not familiar with this document.
Do you recall seeing this tracker or a tracker of this type when you were working on the project?
I couldn't say for certain. I haven't seen it. It's possible that I may have seen it. I can't flatly deny I've seen it, but I wasn't included in the email chain, and it's maybe something that Mott MacDonald were managing on our behalf rather than the engineering reviewing on our behalf. But it's a Mott's document. Yeah.
No, that's very fair. And as you say, you're not copied into the document there.
Yeah.
If we just look at the document, though, if we look down, the left-hand column says department, and if we look at if we could zoom in on the second box down, which is B1, PICU and HDUs, 24 beds. Do you see that?
Yes, I do, yeah.
So again, we see the code B1, which I think you fairly said you didn't understand when you were working on the project what code B1 meant. Is that fair?
Yeah.
But we see next to B1, Mott MacDonald have helpfully added PICU and HDUs 24 beds.
See that?
If you had seen this document, would you have picked up that PICU and HDUs was a shorthand for critical care?
I would have, yes, I would have, yeah.
So if we just look at some of the entries as we work across, we've got the room name still within the B1. We see open plan, bay, 4 beds, the room functions, multi-bed wards. We look over to the room number, we'll see B1-009. We see that the ventilation is natural and central supply air. Supply air changes given as 4 air changes an hour, and the relative pressure is positive. Do you see that?
Yes.
And then we see that there's a box that's been added, compromise, from the 24th of February 2017. Is that referring back to that table we looked at before with the essential rooms written on in manuscript?
I assume so. I can't say for definite, but I assume it would be.
Okay. Just again, so I'm understanding things, what we see is Mott MacDonald producing a table which is saying for these various multi-bed rooms in the critical care department that what they're to have is 4 air changes per hour and positive pressure.
Yes.
Now, if that had been raised with you, if you'd realised this, that what was being proposed was critical care rooms with 4 air changes an hour and positive pressure, what would your reaction be given your knowledge of SHTM?
I would have probably said that this is, again, it would require joining the dots, but that this is specialised ventilation. We should be looking at this as a separate line, if you like, from the others. But
and again, just so I'm understanding things, you've said, I have a general understanding of the guidance, but there's some things that are too complicated for me, and I refer them on to HFS, or I refer them on to a technical advisor. Is that fair?
Yes. Yeah.
Is this one of these types of scenarios where you'd be wanting that more specialist advice?
It is, yeah.
Because on one point there's a possible collision course here, that you have the clinicians on the one hand saying we absolutely must have balanced or negative pressure for these rooms, including in critical care. Yeah. And on one interpretation of table A1, it's saying the exact opposite, that you need positive pressure for a critical care space. Is that right?
Yes, yeah.
And that tension never gets resolved at this point in the project?
It doesn't, no.
And this isn't something that Mott MacDonald's raising as a potential issue?
I think, as I said earlier, no one raised critical care specifically in a ventilation context to separate it out from anything else that was being discussed under the environmental matrix or any other.
The timing of this document, this tracker document in early 2018 might be quite significant, because you tell us within your statement that at this point, really, there's huge tensions within the project.
Yes.
And that leads up to what you describe as a principals meeting at the Sheraton Hotel in Edinburgh on the 20th and 21st of February.
That's correct, yes.
So just a few weeks after this tracker is being made up, there's this principals meeting taking place. What's happening at the principals meeting? What's being discussed there?
What we had in the lead up to the principals meeting, you're right, this was one of the issues that we were raising. This is the issue that almost went to dispute resolution, and between then and the principals meeting in February, we were tasked with putting together a list of issues to be discussed at this principals meeting, and Graham and his team collated that with our agreement, what the issues were to be tabled, and that was tabled at the principals meeting for discussion amongst all parties to see if we could resolve it without the need for court action.
And again, just to understand the standoff that effectively takes place for the 20 rooms, which includes some rooms, some 4-bedded rooms within critical care, you have NHSL and Mott MacDonald saying it must be balanced or negative pressure, and you have IHSL and Multiplex saying it's positive pressure. Is that right?
Yes, correct.
Did you attend the principals meeting at the Sheraton Hotel?
I did, yes.
And do you recall any discussion taking place at that meeting about whether or not any of these rooms in dispute were in critical care?
No, it was more about the principle.
So again, just so that the inquiry understands things properly, there's a crisis point that's reached whereby the parties have fallen out, and there's the diametrically opposing views of what you need to do in these 20 rooms. And while the essential pressure requirements for the rooms are being discussed, nobody's discussing whether they're in critical care.
No.
If I could ask you to have a look, please, at bundle 10, page 111. So bundle 10, page 111.
Thank you.
you see that 3 lines down, there's an so this is effectively a timeline that was prepared at a later point in the project. But one of the entries is 4-bed vent meet, 27th February 2018. Project team attendees: B. Curry, J. Sainsbury, J. Mackenzie, D. Hanley, E. Dewey, R. Henderson. Now, that's taking place just a few days after the principals' meeting at the Sheraton. Do you remember what was discussed at that meeting?
I can't recall that meeting at all, unfortunately. I tried to find anything in my records that could have given an indication as to what was discussed, but I couldn't find anything. So I don't specifically recall that meeting. It may well have been to discuss 4-bed.
Okay. And at the principals' meeting at the Sheraton, had there been a breakthrough? Had there been an agreement on a way forward for the rooms that were in dispute?
Yes, up until that point, Project Go had flatly refused to do it without being paid for it. Basically, they said it was a change on their part, and I think at the principals' meeting they agreed to do the rooms that were deemed to be essential. So it may well have been a follow-up meeting to discuss that.
So again, what happens at the principals' meeting is NHS Lothian says we need balanced or negative pressure, and eventually IHSL and Multiplex, they agree that they will not provide positive pressure, they'll provide balanced or negative pressure.
Yes.
So, right, okay. So that's what happens in early 2018. And as we'll see when we come on to a later stage in the project, there comes a point where NHS Lothian decide that that's not what they want. They want positive pressure for some of these rooms. Is that right?
After July 19.
So in the period after that agreement's reached an outline in February, is there a series of meetings that take place thereafter to try to agree and implement the fine details of the strategy?
Yes, there were meetings. I can't recall how many or how regular they were, but it would TUVSOD were tasked by IHSL to design a installation that would meet the requirements of balanced pressure.
Okay. So we'll just pick out one example. If we look to volume 13, bundle 2, page 1246. So this is a record of a meeting that takes place on the 12th of April 2018. So it's volume 13, bundle 2, page 1246. See, there's a meeting on the 12th of April. The topic is M&E workshop, NHSL/TUV sued. And we see...
That's an example. It's the
See, individual 3 is Camille Kawajczyk. There's a Douglas Anderson, who again is a technical advisor from Mott MacDonald. Colin McRae, a technical advisor from Mott MacDonald, and you're also attending at the meeting. So in the NHSL side, it's just yourself and 3 individuals from Mott MacDonald, is that right? Okay.
Yes.
Can you remember what was being discussed at this meeting on the 12th of April?
I don't specifically recall the meeting itself, but I understand there'll be the documents to support what was discussed at the meeting. But I think these were Doug Sanders, an electrical technical advisor, so some electrical items were discussed, I think, at that meeting. Ventilation was discussed to the point where we were discussing the 4-bed vent. I think there was a general discussion about the environmental matrix as well. But I couldn't 100% say what the meeting exactly was discussed and what came out of it, other than to refer to the minutes and actions.
It's obviously it's not a memory test for you. It's a number of years ago. So if we just look to
I just couldn't remember that meeting when it first came out. When you asked, I can't remember that.
If we look then to I think what's a summary of the key points discussed. If we look to the volume 13, bundle 2, to page 1242. So this is an email from a Mr. Ken Hall of Multiplex to a range of people, including yourself, and the subject is 12th April 2018, 4-bed workshop summary. Do you see that?
Yes.
Okay. It says confirmation of the key points discussed. 1.0 says SM noted concerns and agreement from the previous workshop number 1 that the objective of workshop number 2 was to obtain agreement in principle on the draft drawings being tabled to allow progress to continue on 4-bed design. This was due to NHSL held up at another meeting and no delegated authority at the workshop. And then the action says, concerns resolved as Ronnie Henderson joined the workshop at 1:30. Do you see that?
Yes, I do.
So again, just to understand your role, were you really in a decision-making role? Did you have authority to sign matters off on behalf of NHS Lothian?
I didn't. We would go to these meetings and discuss in principle what was to be designed, and either raise concerns or not, as the case may be, and take back a recommendation to decision makers, which would be Brian Curry and Janice McKenzie. But I had no authority to decide anything at these meetings.
So again, just understanding the chain, you're at the meeting having discussions, but if there's to be any final sign-off, that's Brian Curry, Janice McKenzie that are taking that level of decision-making.
Yeah, absolutely, yeah.
If we just look volume 13, bundle 2, page 1242, and then there's a bold heading A, 4-bed agenda item. Do you see that?
Yes.
And it says, rooms in question tabled across on the previous Rev 5 schedule, rooms cross-reference drawings against the schedule, see attached schedule and drawings overviewed, and then room M type, NHSL noted environmental matrix, notes supply and extract, drawing table and site inspection has no changes to the extract. Do you see that?
Yes.
And if I could just ask you to bear in mind that letter M, because we'll come on and look at that in a moment. And then item 4, areas I and J, NHSL requested actual air change rates be confirmed given the increase in one extract system rather than perhaps introducing it across the 3 systems in the locale. Do you see that?
Yes, I do, yeah.
So specific discussions taking place at this meeting in relation to what the actual air change rate should be?
They are, yes, and that was to be confirmed with the schedule of 4-bedded rooms.
Okay. And again, if we just think back to the model that was meant to be implemented, whereby all of the design risk sits with Project Co, why do we see now NHSL having discussions about air change rates rather than simply saying to the design team, comply with the published guidance?
Well, I think we were saying that throughout the entire project, but we got to a level of detail with this specific item that in order to achieve balanced and or slightly negative pressure at the doors, these things came into the discussion. And the schedule that was tabled had all the rooms at 4 air changes, or should have had all the rooms at 4 air changes, and this was a way of clarifying that all the rooms were going to be. Because, again, my own thought was that all these rooms were in general wards, not in critical care, so the general ward single bedrooms had 4 air changes mechanical and 2 natural. The assumption would be that to comply or to meet the guidance that HFS had also provided, that would be the same for these 4-bedded rooms.
So again, just so I can understand things, at this meeting, and this again, you're there, there's 3 technical advisors from Mott MacDonald, and there's also people here from the Project Co side. Is anyone raising the fact that these rooms are in critical care?
No one's raising the fact that they're in critical care meaning anything at all. But whether critical care may have been mentioned at the meeting, I can't definitely say, but no one is saying specifically at that meeting critical care should be separated out from this discussion because it has different requirements.
So nobody's saying specific pressure regimes for critical care and specific air change rates for critical care. That's just not happening at this meeting.
No.
We could return to volume 13, bundle 2, page 1242, and it's item 6 towards the bottom. NHSL confirmed agreement in principle to the strategy tabled and to proceed to the next stage of site survey based on drawings tabled. thereafter RDD pack to be submitted for speedy approval. Do you see that?
Yes, I do, yeah.
By this point, is there really an agreement that's reached at this point between NHS Lothian and Project Co as to exactly what's going to happen for these 20 bedrooms?
In principle, based on the fact that they were all assumed to be general bedrooms, then yes, that agreement is in place, or in principle, to say that all these rooms need to have balanced.
Okay. And if we look at item 7 and then just the final line on that page, it says supply no impact is being maintained at 4 air changes per hour, or ACH, as per the environmental matrix. Do you see that?
I see that, yes.
So again, at this meeting, is there really firm agreement that what is going to be in place for these rooms is 4 air changes per hour?
Yes.
And there's no objection being taken on the NHS Lothian side, is that correct?
Yes. Yeah.
And Mott MacDonald aren't raising with you saying you need to stop this because you need 10 air changes an hour, these rooms are in critical care?
That's correct.
And that's not coming from the Project Co side either. IHSL, Multiplex, TUV Sud, nobody there is saying we should be having 10 air changes rather than 4.
That's correct, yeah.
And equally, there's no discussion about derogating down. If these rooms are in critical care, nobody's thinking about a formal derogation to go from 10 down to 4, are they?
No, that's never mentioned.
I said I'd come back to the potential significance of the letter M. If I could ask you to look at volume 13, bundle 2, please, at page 1265. So this is another iteration of a document we looked at before, which is the TUV Sud General Ward Ventilation Amendment Proposal to Achieve Room Balance. Do you see that?
Yes.
So it's volume 13, bundle 2, page 1265. Lord Breeze, just a couple of references. You have to proceed just on the
I think
screen.
I'm happy in the moment to work off the screen.
Thank you.
It's okay. Okay, David.
This is just another iteration of the general ward information, the various iterations being in the bottom left-hand corner. But if we could look on to page 1267, please. Do you see room M there being mentioned? And that again has got the code B1065, so B1 being the shorthand for critical care. Do you see that?
I see that, yes.
And then if we look down to page 1270, this is just a further iteration of the same document we're looking at. It's signed off on the 31st of May 2018 by Brian Curry.
Yep.
But do you see the handwritten notes in the bottom left-hand corner in manuscript?
Yep.
Entry 2, it says rooms, I think that's B1063 and a couple of others, including B1009, do not have en suites. Do you see that?
I see that, yes.
Okay. So again, if you now know that the room code B1 means critical care, and we're seeing that these rooms don't have en suites, if you had seen this document at the time, would that have been helping to join the dots in terms of these rooms being in critical care, or would it still not have helped?
It may well have done, but I can't. I honestly look back on that and think to myself, well, why each document, and as you see it there, has a kind of sort of either an explicit reference or a kind of tacit reference to it, and I can't say if that would have definitively let me join the dots, but it would have helped to have had shoved in front and said, you realise this is in critical care and it has a separate requirement in the guidance, and that never.
So in terms of just sort of understanding things, if we're looking at this type of document that's got a B1 or a reference to an en suite, is your evidence that it may or may not have made a difference?
It may or may not have. It would depend on, as I've said, and I keep using that saying, I'm sorry, joining the dots. It would have depended on joining the dots at the time.
But should we really understand if we're talking about a real missed opportunity, the real missed opportunity is round about the generalised risk assessment that specifically says these rooms are in critical care?
If you put it like that, yes, it is. Yeah, I mean, it's unfortunate, but we didn't pick up at the time that, you know, these rooms are in critical care, and the reviews all carried on of the schedule based on that.
Well, it's important to understand what your position is. Do you think the generalised risk assessment that we looked at from 2017, do you think that is a missed opportunity, or was that still a scenario whereby clinicians were saying we need balance or negative pressure?
Well, clinicians were still saying in balance on negative pressure, but where you could perhaps phrase it as a missed opportunity was it was an opportunity for technical advisors to go back to the clinicians and say, you do realise that this room has separate requirements. It was an opportunity for Project Co and its team to come back to us or our clinical teams and say, you do realise that critical care has separate requirements. You're effectively asking us to provide something that does not meet the guidance.
That takes care of the issue of pressure.
Yeah.
But it doesn't really deal with the issue of air changes, because within the generalised risk assessment, the clinicians weren't saying, please reduce this down to 4 air changes per hour. So how do we come to a scenario when we're in 2018 and we're looking at some of the air change rates and they're 4 rather than 10 for critical care spaces?
Again, I can't explain how that was overlooked or missed. That's the only explanation I can really give to it is that schedule of 20 rooms, in my mind, were 20 rooms that weren't in critical care or hadn't registered that 4 of them were in critical care at that time.
Thank you. Just on that issue of air changes, if we could look within bundle 1, please. And look to page 2042. So that's an email from Ken Hall to Stuart McKechnie and others, dated the 18th of April, 2018. So bundle 1, page 2042. Perhaps just while the document references are being achieved, can you just, we'll come on and look at the detail of this email. Is this an email that you remember having a look at? And is it an email that you remember being copied into?
Yes, I do, yeah.
And can you just explain, before we look at the detailed text, what's happening in this email exchange?
Well, this looks like, again, I wouldn't have recognised it if it came up on its own, but it looks like the timing of it was immediately in the aftermath of that meeting you referred to earlier on. And the schedule that came with the documents associated with that meeting had the schedule still showing air change rates that were less than 4 air changes per hour. And because the view was that these rooms were all general 4-bedded rooms, 4-bedded wards, whatever you want to call them, they were all to have a minimum of 4 air changes per hour. And the schedule was showing air changes less than that. Okay. So that's the reason for that email.
I'm conscious that it's just before 1 o'clock. I think that is quite an important email that I would like your lordship to have in front of them, if possible.
Right. Well, we take the lunch break now. Mr. Henderson, we'll take our lunch break now and we'll sit again at 2 o'clock. So could I ask you to be back in the witness room and ready to start again at 2? But I'll ask David if you could take Mr. Henderson out. Of course. 2 o'clock, ladies and gentlemen.
Please stand.